pregnancy is a normal, natural life event that sometimes requires medical intervention. We do know that that happens, but it's not a medical condition that can sometimes be natural. So I just want to put that out there. There seems to be some really fun connotations. With pregnancy, again, some may need assistance, some may need doctors, some may be higher risk. That's totally understandable. Our bodies are all built very differently, but there are a few elements that every single woman can control in her pregnancy to help with a healthy outcome. And so they're education, nutrition, and exercise. So with education, part of midwifery, I'm going to try not to jump too far ahead, is that it's very education heavy. Informed consent, informed choice, understanding your body, understanding pregnancy, understanding birth, understanding postpartum it's imperative when you're having a baby, particularly out of the hospital. And unfortunately, in our society, you don't learn anything about being pregnant or having babies until you do it. So particularly in my practice, we're huge proponents of education. Not only do the clients get to listen to me drone on for an hour about whatever we're talking about, but we also have the moms who have not already had an out-of-hospital birth all participate in childbirth education classes that are led by the assistants so that they can really have a firm understanding of what they're about to experience and what that looks like for them and how to get through it. So we have listed a few different options. I can't see this at all, actually. I'm trying to look at both. You have your general childbirth classes. You can usually find them in your local community with your midwife. Hospitals do offer childbirth classes. They teach you how to be a very good patient. So I highly recommend getting one that is external to your provider if you want the informed choice aspect. There's other things like hypnobabies and hypnobirthing, Christian hypnobirthing. All of those help to relieve the discomfort during labor. There's the Bradley method class. Again, we already said local private classes and even online classes like Mama Natural that can be very, very helpful. Nutrition. Nutrition is my favorite thing to drone on about in prenatal visits because nutrition is the best indicator for a healthy outcome, period. Granted, there are things that can happen. There are anomalies. There's things that can pop up throughout pregnancy. But in general, the best way to move yourself in the direction of a healthy outcome and avoid complications later in pregnancy is nutrition. And so that is really well encompassed in general in homesteading, right? I think that most of us have a pretty good understanding that what we're finding in the grocery stores and what we're being told on My Plate and things like that maybe aren't actually our healthiest options. So we do a lot of nutritional counseling prenatally so that moms really understand what a healthy pregnancy looks like and what a healthy diet actually is, not what we've been told a healthy diet is for the past 20 years. So nutrition can help mom in a lot of different capacities. You can use nutrition to treat symptoms like nausea, vomiting, indigestion, constipation, all of the beautiful gifts that come with being pregnant. It helps with healthy maternal weight gain, right? Weight gain seems to be, again, also in America, a really big thing. Like, how much weight do I gain? Have I gained too much? Have I not gained enough? If you're eating the right foods, you're fine. Your body is really, really well designed. I don't know if you know this, but our creator did a pretty good job. And it will all take care of itself if we're eating good, nutritional whole foods. It reduces the risk of maternal anemia, which is like low iron, and increases your risk of bleeding later. So things like lots of beef liver, which everybody loves, red meat, cooking in cast iron, all the things that we probably all do. And then the biggest thing is that it reduces the risk of preeclampsia, hypertension, and gestational diabetes. Now, all three of these things are typically our biggest risk out factors, the things that make moms high risk towards the end of pregnancy. And they all tend to sort of arise in the third trimester. So for anyone that's had babies, you do that glucose drink that's disgusting at 28 weeks. That's gestational diabetes screening. And for anyone who has unfortunately gone through preeclampsia or hypertension, those generally also arise later in pregnancy. But what a lot of studies have shown is very high protein, high fat, high vegetable diets, surprise, are highly correlated with healthier pregnancies and a significant decrease in those complications popping up later on. They also help baby. Obviously, you can get through a pregnancy on McDonald's and Coke. I'm sure babies are really resilient and they really want to come out, but it's not always our best option. Eating those healthy foods, particularly fats, help with brain development for your baby. Healthy birth weight, right? We don't want a baby that's too small. We also don't want a baby that's maybe a little too big, although that's not as common as you think. We'll get there later. And then it can also reduce the risk of birth defects. And we all hear about things like, oh, eat your folate and you need your prenatal vitamin. And I won't get into a big, huge rabbit hole on prenatal vitamins, but just a healthy reminder, but they are designed for an American diet. And if you are eating a whole foods nutritional diet, you will need less of those supplementations. And of course, everybody's favorite, exercise, because when everybody's in the third trimester, they want to go for a run. But in reality, again, exercise kind of goes hand in hand with nutrition. It's a no-brainer. We know that exercise helps our health in general overall. And pregnancy, I mean, it is just another walk of life. The same things that keep you healthy in a non-pregnant state keep you very healthy in a pregnant state. And so there's lots of different options. You don't have to train for a marathon, but low to moderate exercise 2 to 3 times a week, 30 minutes a day, which is the general consensus anyways, can help to keep you nice and low risk. So you can do running in early pregnancy. Some women really like yoga, Pilates. I'm a huge advocate of HIIT training. It might seem really intimidating to a lot of people, but it's extremely modifiable to whatever you're going through and whatever your needs are. And then walking, of course, and swimming is fantastic if you can find a pool. Good luck. All right, so those are the things we can control. Here are some things that we may not necessarily be able to control or that do comprise that small percentage of women that may not be good or suitable for an out-of-hospital birth. And this is just, it's the way that the cookie crumbles. Sometimes it happens. I'm going to come to this one because it's easier. In some cases, if you had a C-section that was not a low transverse uterine incision, generally speaking, you don't see that anymore, so that's not very common. Pre-existing or chronic hypertension, medication-dependent diabetes, seizure disorders, of course, if you're abusing alcohol or drugs, cigarette smoking, hyperthyroidism. I may not go through this whole thing. I mean, they're pretty understandable, right? These are not low risk, easy peasy, run of the mill, but they also don't comprise most of the population. And in fact, 80 to 90% of all pregnancies are low risk, period. So here's a fun fact, and this isn't meant as a dig on doctors. I want to just throw this out there. I love doctors when we need them. I love them for the things that they can offer when we need them. And also, the United States is not doing the very best that we could in maternal care. So the U.S. is actually ranked 46 in the world for maternal outcomes. It's the lowest in all developed countries. And so I really like that to settle in a little bit, because out of all the developed countries in the world, we are extremely wealthy, we have an abundance of resources, and we suck at it. So, again, it's not a dig on the hospitals. It is the hospital protocol. It is the establishment. It's the institution. I don't think that doctors are bad, but we have not set ourselves up for a lot of success in this area in the hospital protocols. So we're actually the only country developed country with increasing maternal mortality rates, which is also highly unusual. The rest of the modern world has managed to decrease those mortality rates for moms and babies. And yet, in the United States, mostly due to intervention, ours are actually continuously increasing, which is the opposite of where we want to be. And the really unfortunate part of it is that 2/3 of maternal deaths in the United States are entirely preventable. And then also, the other significant factor, and something that I think is always important to bring up, is that there is a huge racial bias endemic in the United States, and women of color are astronomically more likely to die in childbirth than a white woman for a myriad of reasons that I won't get into, but there's an enormous disparity, and that also goes all the way back to that same institutionalization. So again, this isn't a dig at the hospital, but to give you a concept of what that might look like and why these outcomes are the way that they are. It's not that doctors aren't doing their jobs. It is the protocol that are put in place for pregnant women when they're brought into care. So when you're brought into care, often moms are brought in early for induction, right? For fear of big babies, or they don't want moms to go to term, or whatever condition they have decided that moms need to be induced for. And then that induction, even if they're not induced, typically it's either that or you come in and you're augmented because it's a business model. So the hospital is a business and they have to turn beds. And there are many, many women giving birth all the time, every day. And there is actually quite a drastic shortage of obstetricians in the United States in the first place. So they have to roll those beds out. So it's not like where when you come into a birth center or you have your baby at home and you can have 3 days to have your baby. You come in and you have a few hours to move along. And if you're not, we're helping you. So that typically looks like induction or augmentation. That's used with Pitocin. For those of you who don't know what Pitocin is, they also call it oxytocin, which is a scam because oxytocin is a natural hormone in your body that causes uterine contractions. Pitocin is synthetic. Your body creates oxytocin in these nice waves biologically. And with those waves come your body's natural pain relievers and endorphins in your natural biofeedback from the mechanisms in your body, right? This is a normal, natural thing. Pitocin is an IV drip, and it's just given at a plug-and-play method. Oh, that's too much. Oh, that's not enough. But the uterus never gets to fully relax. It's always in a little bit of a contracted state, and it is often far too much for our bodies to handle. Our bodies are designed to withstand contractions. You are perfectly capable because your body knows what it's doing. It's not putting you in danger. Unfortunately, with Pitocin, there are limits, and so we have to just kind of guess where that line is to where it's too much for baby or where it's not enough. Because now you're not getting natural hormones and it's synthetic, you're also not getting your natural biofeedback, and those contractions are a lot more intense. This, in turn, makes it much more painful, so most moms will request an epidural. It makes sense. This isn't a natural process anymore. It's incredibly uncomfortable. Moms get the epidural. With an epidural comes restrictions. You need to be in the bed. You have to have an IV. You need to have a catheter. You don't have mobility, the ability to move around and make yourself, one, help labor move along, and two, just feel better in general. So you have more restrictions. That results in a slowed labor. So then they give you more Pitocin, and then your baby's in distress, and then you get a C-section. And in general, I'm summarizing and oversimplifying, but in general, this is why we have a 33% cesarean rate in our country. So, again, it's nothing against hospitals, but this is kind of what you get. This is the business model. This is how we turn doors and get beds rotated. So, that said, there are different types of approaches to healthcare when it comes to maternal care. You have humanistic, which is typically the midwifery model of care. And then you have technocratic approach, which is the medical model of care. So in a technocratic approach, you're going to have that same business model that we talked about. They're turning doors. There's not really a relationship. It's very directive care. This is what you're doing. We're going to check your cervix now. I'm going to break your bag of waters. We need to do a C-section. It's very directive. Much higher rates of unnecessary labs, ultrasounds, and interventions. Oh, we couldn't see that very well. We need a scan. Oh, your baby's 40 weeks. We need a scan every other day. Things like that. It's very fear-based, right? Instead of just giving you the information and allowing you to make the decision for yourself, it's often implied with fear-mongering comments like, well, okay, but if your baby dies, it's not my fault. So that's a fun one. Unfortunately, is extremely litigation driven. Again, it's the hospital. It's a huge business, very, very directed by litigation and protocols. And then there's typically a larger practice with an on-call rotation. So you might really love your obstetrician, but you are probably not actually going to get your obstetrician when you go to the hospital because they work on a rotation. So that's really like playing Russian roulette with your favorite provider. And in general, they're shorter appointments. in all fairness, I've never actually received OB care. I've been very, very fortunate to only ever see midwives. But from what I understand, they're very brief and very concise. There's not a lot of wiggle room for questions, and they last about 5 minutes. What I do know about midwifery care from my own personal experiences and from what I provide to other mothers is that it's highly individualized. Every woman, every baby, every body, every circumstance is incredibly different. Every mom has different wishes for her birth. Every mom has different goals. Every person has their own views and philosophies on birth that we need to respect. So it's very individualized to those moms and what's important to them in their pregnancy and their childbirth. There's continuity of care. So in my practice, at least, I'm a sole provider for now until my students, graduate. But it's not that Russian roulette game. You either love me or you don't hire me because I'm what you get and I'm there the whole time. So it's just one person, which typically our moms really like. They want to know that you're showing up at their home. They want to know that when they show up at the birth center, you're there to take care of them and that you're going to be there without shift change or anything else until the very end and follow them all the way through. Again, very heavy in informed decision-making and shared decision-making. So that education piece with every prenatal appointment is just packed with information about why are we making these choices? Here are your choices. Here are the risks and benefits. What do you think? What do you feel? And unless it's wildly dangerous or inappropriate, we go with your plan because you're the sovereign authority of your body and you get to decide what works best for you and your family. So if you don't think that you're at high risk for gestational diabetes and you don't want to do glucola, you can do an alternative. You can do whatever you want because at the end of the day, you can walk out my door in free birth. I don't recommend that. But at the end of the day, we want to support you, not to force you out into trying to make choices on your own. We use the lowest necessary level of intervention. Intervention does have its place. Sometimes we really can benefit from castor oil or breaking someone's water or whatever intervention you want to insert there. Sometimes that can be helpful, but we only do that when we need to do that and when a mom has asked for it and consented to it. We use holistic treatment methods. So for instance, for bleeding, we would use herbs before we would go to meds, which might sound a little wooey, but at the end of the day, God also put those there for a reason, and they are highly effective. And if you really stop to consider it, those pharmaceutical methods are modeled after all of those herbal methods and the natural things that your body does in the first place. So we look for the natural process first and go from there. And then one of the biggest things is midwifery is preventative care, right? And our medical model doesn't like that. They like you to come in when you're too sick and you're too far gone and they want to treat you. We want to work with you to help you stay healthy and stay low risk so that you can have a beautiful out-of-hospital birth. And we start by preparing you to prevent things and complications that might arise, as opposed to waiting until they've arose and said, oh yeah, you have preeclampsia and you probably could have eaten better or exercised, but we'll just induce you. So it's a little bit of a different approach. And then typically our appointments are 30 minutes to an hour. Probably at this point, most of you know how that feels, but it is very useful for an educational purpose to have time to sit down with your midwives and ask questions. And it sounds like a lot, but it's generally very helpful because it gives you an opportunity to actually connect with your midwife, to build a relationship, and to truly understand where they're coming from, and for them to truly understand why you want what you want and how we can help you meet your needs. All right, we're almost there. So natural birth. Natural childbirth can occur in a hospital. And I should also add that I highly believe that every woman should give birth where she's the most comfortable. And if you want to give birth in a hospital, that is absolutely fine. It is up to you where you feel the best and most supported. The only thing with the hospital is that you just want to have a plan. You want to make sure you have a provider that supports you, and you want to make sure you understand what is happening. But you can absolutely have a natural childbirth in the hospital. Most doctors haven't seen it, but it does exist. There's also birthing centers and home birth, which kind of are self-explanatory. And what I mean by natural birth is that it's unmedicated. So there is no induction, there's no Pitocin, there's no epidurals, there's low to no intervention, and it's a spontaneous vaginal delivery, meaning obviously at home, we're not performing cesareans. Back to that hospital birth. Again, I don't hate hospitals. This just is what it is. They do have more aggressive protocols. It's litigious-based. They are very strict in their protocol. It is more of a cookie-cutter method. So they have this very linear approach to how they deal with each process of labor. It's, again, very directed decision-making. You have more restrictions. You are put on a timeline, and unfortunately is a business model. So what you can do to support yourself if you choose that the hospital is the best place for you and your family is just be informed. Make sure you have a supportive partner that can advocate for you, because when you're in labor land, you're not thinking cognitively in the first place, and you certainly shouldn't be the one putting up a fight for yourself. So make sure your partner is on board with your plans. Please hire a doula. Let them come in and help you advocate for yourself. Let them come in and help guide you through the process so you don't feel alone, and so that you have at least one piece of continuity of care through your birth. That one person is going to be there from start to finish with you, and at least you can rely on that. It's a person you know. It's a person that you trust. It's a person that will be there with you, and it makes an immense difference. Have realistic expectations, right? Remember what you're up against. Side note, you can't go into the hospital and start declining all the things and expect good treatment, right? Have a realistic expectation of what they're going to want from you and what you're going to likely have to be willing to do in order to be there. Don't go too early, right? Don't go when you're 1 centimeter. The less time there, probably the better. And then advocate. Advocate for yourself. Have your partner advocate for you. Have a doula that can help empower you to advocate for yourself again. And then at the end of the day, it's self-responsibility, right? This is 2023. I don't mean this to be unkind, but we really don't have any excuses. I mean, Google will tell you everything, and half the time it's probably wrong. But if you want to know what's going on with your care, you have the resources. You have a way to look it up. So make sure you're relying on yourself as well and not just leaning into what the doctors tell you, because that's a recipe for a bad experience. All right, doulas. So these are those things that I was talking about that you can bring with you to the hospital. So it's not an inanimate object. It is a human being, often women. I mean, it makes the most sense that way to me. But doulas tend to result in increased success with natural childbirth, shorter labors, much lower need for pain management, decreased C-section rates, reductions in epidurals, reduction in mechanical delivery, and a reduction in Pitocin or augmentation. Why? Because you don't go hike Mount Everest without a guide. You go with your doula. They help you navigate the water. They help you translate the language, and they help get you where you are and support you when everyone is waving that epidural in front of you like a chocolate bar because they want you to just do their plan instead. Benefits to a natural childbirth, don't mind me skipping around, are that in general, it's safer. So again, I talked about those outcomes and those rates in the United States. If you look, you'll see a lot of information that says, oh, home birth is so dangerous. You're so much more likely to die. And that's actually not true. And if you do a little bit of digging and you look at who's writing those papers and you look in other countries, right, where their outcomes are better than ours, you'll see that births that are attended by a skilled, educated attendant, typically midwives everywhere else outside of North America, they have better outcomes than obstetricians. Why? Because obstetricians are surgeons. Obstetricians don't understand natural childbirth. They are not well versed in childbirth. Midwives in general, are the experts in natural childbirth, in natural, right? Obstetrics, surgery, midwives, natural. So it would make sense that in the countries that use midwives more, they have better outcomes and it would be safer. Why? Because midwives aren't using interventions at the same rate that doctors are. You have the benefit to move and change positions. Go figure, moving your body can help your baby come out because we're not meant to be rigid when we give birth. There's a reason that our body moves and that our pelvis can move and things can be manipulated for childbirth. Again, less intervention, less likely to tear. Everyone's always very worried about that. You're not getting an epidural and purple pushing, launching a baby out. So that decreases that risk. Of course, improved bonding and breastfeeding relationship. In the hospital, they often have, again, their protocol. They need to take the baby. They need to do these things. In an out of hospital environment, the baby is placed on the mom's chest. And immediate skin to skin and breastfeeding are initiated. And we tend to try to leave that first hour as undisturbed as possible. So you have a much greater chance of breastfeeding, and you have a much higher rate of bonding. Faster recovery after birth. Sorry, I know. Oh my gosh, I'm so tired of hearing myself talk at this point. Okay, faster recovery after birth. And then, of course, empowerment and a decreased rate of cesarean. And I won't get too lost on the empowerment, but I do think that, again, birth and bringing a child into this world is something that we have just totally lost reverence for. But it is one of the most important things that we do as women, period. It is one of the most miraculous things that occurs every single day. And so to strip that power away from women and to take that dignity away and take away those choices, it's awful. It's a travesty. Women should be empowered because you are so strong. You are so amazing. You bring life to this world and then you sustain that life with your body. You are amazing, to say. Okay, and then we have home birth and center birth, which I've rattled on a little bit here and there, but I think the main and obvious differences are home is, well, it's at your house. A center birth is typically at an established residence or building where they have set it up to be a home-like setting. The biggest difference between the two is your house. There's actually not a very significant difference. Midwives, we bring everything we need to your birth. We just have these wonderful traveling bags, and our cars are always loaded with all of these super fun things to bring. So we bring all of those same things and interventions we might need for a birth center birth to your house. Although for some families who have really big families and maybe they don't want their 6 kids crawling all over them, which is totally understandable, or they live on top of a mountain and you can't get to them, they might want to choose a location that is less rural or more accessible. Okay, great. I got to my finish line. So that's kind of the gist of it. At this point, because I've been rambling for so long, I want to open it up for questions, both for me if you have questions about hospital birth, out of hospital birth, and then also I have asked my assistants and one of our moms to come up and sort of sit on a Q&A panel so that you have an opportunity to ask them. They've had hospital births, they've had birth center births, they've had cesareans, they've had home births. I have had home births, and I've attended a lot of these things, but I've attended them as a practitioner, not as a mom. And so they can speak to all of this from a mother's perspective and having had the care and treatment of a midwife versus the care and treatment of a doctor. So come on, ladies. Okay, who wants to ask questions first? Go. Wait, I think I'm supposed to give you a microphone. Here, I can go give it.
So I've had 2 deliveries. One was a great vaginal birth. Second was an emergency C-section. As I prepare for hopefully a VBAC for the 3rd baby, what's any recommendations or advice that you guys would have?
I had a VBAC last year actually with Jen. So I think first of all is just do your research. That's the best thing. And just know you can have a VBAC. They're going to try to scare you into all these crazy things that they don't really happen. It's very rare. I have experience as a postpartum nurse, so I'm saying that with that. But don't be scared. They will also tell you if you go see an OB, they'll tell you you have what's called a proven pelvis because you had a baby before. But also interview a midwife and just see what are my options. What do you think about this? Are you scared to take me on? What are my risks if I want to have an out-of-hospital birth or just a VBAC in a hospital? I do find that out-of-hospital midwives are usually more open to VBACs, but it is possible to find a provider who will support you. You just have to do the research and you have to be willing to do the work and hire a doula. That's the best thing you can do. I did that. Maggie was my doula, and it was everything. Okay.
I'd also,
Nothing, go.
I'd also add too, for anyone I've supported a lot of VBACs. I know we've had a lot of VBACs at the center, but making sure to realize that this is a new baby and a new birth. There's a lot, whether we've had really good births or we've had a really hard and traumatic birth, we hold on to that as moms, and we will, whether we're conscious of it or not, take it into our next birth. So make sure that you're taking the time to process that. If you need to talk to anyone, write it down. And I mean, take it to prayer, like making sure you know that this is a new baby, this is a new birth, and that baby is going to work differently with your body this time as well.
I also had my first vaginally and then a second C-section. So, and I've had 3 VBACs since then. So I would say the same thing. Like, it's a totally different birth, and getting that support and knowing you have that support can just make a world of difference.
Yeah, that's right.
Good morning. Hello. There we go. Okay. So one of the things I really wanted to ask, advanced maternal age, is that truly a risk factor? Because there seems to be a lot of varying opinions among practitioners on that. And I'd love to hear your thoughts.
I have so many. I think advanced maternal age is a really fun term. I think what they also call it geriatric pregnancy. That's super fun at like 35. So that's interesting. Unless you're 80, I think you're probably fine. Again, our body was designed so brilliantly, right? That in general, if our body's not meant to have a baby, it probably won't conceive and grow a baby. So I would say in general, again, never say always or never, but in general, if you have a normal pregnancy at an advanced age, I mean, it's just okay. Yeah. Does that answer your? I mean, there are risk factors, right? And they'll tell you, oh, your risk factor doubles for Down syndrome from like 0.001 to 0.002, and you're like, okay, and yeah, and that can happen to anyone. So, it's one of those things. Like, it's pregnancy. Your age can definitely make a difference. And there are things that we look at maybe a little differently. Primarily, I would say nutrition is one of the biggest ones. Again, right? Because generally, even as we get older, our health tends to decline. If we've had a lot of children, our health has kind of declined a little bit because, again, those babies, they just really want to live. So they just pull everything out of us. And we have to be able to replenish that. So we have to be smart in how we approach it. But I certainly don't think that it precludes someone from being able to have a baby by any means.
Is it on? There we go. The reason why I asked is because, and I'll give you a perfect example. Like you were talking about conventional medicine, and I'm an integrative health practitioner. I do women's and children's. Birth is not necessarily my forte, but my OB herself said, well, we have to do all these scans. We have to do this. We have to do that. Now we have to. Anyway, it goes on and on and on. And she says, but I was 37 when I had my last one. And I said, oh, and did they do all that for you? No. And how did that go? I was fine.
That's right. Yeah, that's right.
For those of us in different states, like I'm based out of North Carolina, what are the resources, or how should we search out a doula or a midwife in our relative area?
Where are you from?
Outside of Raleigh, North Carolina.
So I actually worked with a home birth practice in North Carolina. North Carolina, for those of you who don't know, and I didn't delve too much into that, some states are extremely restrictive. Some states don't actually even allow midwifery, right? And so these midwives are totally under the radar. New York was really, really bad for a long time. They still are. Florida's pretty not fun. North Carolina, CPMs are actually illegal. So you can be prosecuted and jailed for helping women have babies. There's a fantastic midwife named Olivia Marshburn, and she's in Homestead, just FYI. But there are a lot of doulas in that area. And I would say, in general, Google's going to be your best friend. But you can also get on, I mean, Facebook has so many groups. Now, if you even go into like natural pregnancy, natural parenting groups on Facebook, you can ask sort of where your region is and who use doulas, because doulas are unrestricted in every state. So that's the easier one to find. But I would just maybe reach out. I know that there's a couple around you and just kind of interview with them and see. And that goes for everybody. Unfortunately, there's not like a secret underground network of midwives where like we know all of the midwives. We are pretty tight knit, right? Because we do make up a small portion of the United States. But yeah, I would say generally speaking, Google, or you can just kind of pop around in those groups and find natural or home birth groups for your area, and then they'll have recommendations.
Kind of going back to the VBAC discussion. So I've had 4 children, 3 of which have been C-sections. The last 2 extremely traumatic, to the point where I can barely walk in a hospital for any reason, because they nearly killed me. My husband was literally a single dad of 4 children while I was stuck in the hospital. But we have discussed the possibility of having more children. But would you yourself, or do you know anybody who would take on a client who had several C-sections? Or do you think that's just kind of too much?
So with midwifery, you will often find a very wide spectrum of beliefs. And there are some midwives that believe that, I don't want to put words in their mouth, but maybe like there's no such thing as risk. And then there's other midwives that are like, everything is terrifying, right? So you have a spectrum of in between. And I would say that it is generally, just being honest, it's going to be much more difficult for you to find a practitioner that's willing to take that on. But it's not impossible. There certainly are midwives that will work with moms that have had multiple C-sections. You just, at the end of it all, it boils down to informed choice. And that informed decision-making, both parties have to be in agreement that they both feel safe. So you have to really, truly understand the risks and potential consequences of that.
Right.
Not that it's like horrifying, right? And for a general VBAC, it's a joke that they even make such a big deal out of it. But, you have to make sure that you understand, and this is for any condition in general, you understand what's going on with your body, what those risk factors are, and then your provider has to also feel comfortable, and then you form a plan together. So it's not impossible. You certainly can find providers. It just takes a little more work.
Yeah, we live in North Carolina as well, and Google has not been my friend. So
yeah, you might want to. You could look at the farm.
We're right in the middle where I feel like 2 hours to Virginia, 2 hours to South Carolina. I'm willing to make the drive.
I was going to say, you have the farm in Tennessee. You can go to birth centers out of states. We've had clients who have lived out of state that have come and stayed, and people who are Airbnb outside of the, in the area until their birth. There are ways. It can happen. You just, again, and it's really, really hard, and I probably shift another. It's really hard to give super individualized answers because, of course, I can't offer medical advice. I don't know what the conditions were or the reasons were for a lot of things that do happen in women's labors. And so that's not to minimize you or anything like that, but it's really a precarious question, right? Because there's so much that goes into it. There's so many variables that go into it. So the bottom line is you just have to reach out, right? What's the worst they do? You say no? Sure.
Thank you.
Yeah, of course. I'm really sorry that happened to you.
I'm also in North Carolina. So,
oh, man.
And I have not had any children, and I'm 31. And so my question would be, as someone who doesn't have any experience, like, communicating with an OB, no, experience with childbirth, anything like that, like what would you look for in an OB if you're wanting to do something like a home birth or a natural birth? Like what qualities would you look for in an OB that would be, supportive of either, having a doula or a midwife? Like what would you look for?
Can you say more about that? When you say OB, are you talking about a hospital birth?
Well, I guess in general, like those ladies that are having, like maybe if they want to have a home birth, like do they go to the doctor at all?
Oh, that's a great question.
Yes.
I can't believe I didn't even touch on that. Midwives replace the need for an obstetrician, right?
Okay.
Midwives, again, are the experts in maternal care. We do your labs. We send your requisitions for ultrasounds. We don't just walk around and like burn sage and chant. We're very educated. We're very skilled. Like we replace the need to go to an OB. So you don't require dual care. Your midwife is your practitioner. Your midwife is who does your prenatal visits, your vitals, listens to baby, helps guide you throughout the pregnancy, and attends your birth. They do All of it.
Okay, that's
We're
good to know,
unicorns.
'cause
It's
I
wonderful.
wouldn't want to have someone that's helping me along, and then you go to the doctor and you tell them you have like a midwife or a doula, and they're like, oh well, what they're telling you is wrong. Like then you have to go back and forth between like fighting for yourself versus that sort of thing. That's very good to know.
That's the hospital, and that is obstetrics. Most OBs, if you ask them about a home birth, are going to roll their eyes at you or say good luck or try to scare you out of it. There are some OBs that are incredibly supportive, and I thank God for the ones that are. But in general, if you're asking anyone within the medical system, they probably don't want you to have a doula because doulas help you get what you want, not what they want. And they probably will laugh at you if you ask about a birth center or a home birth because to them, that is just too risky. Unfortunately, again, it's not because they're bad people, but they're misinformed. They're misinformed. They're indoctrinated by medical schools who are paid for by pharmaceutical companies, and they have this streamlined belief, and they work in an environment that is just totally, it's driven by fear. It's driven by litigation, and they don't really want to think anything outside of it that challenges their views. That critical faculty in our brains that shut things down when we don't understand or it's something new, they don't like that. So, in terms of trying to get back to your original question, I think all first-time moms can have an out-of-hospital birth. And I get that a lot. Like, well, I think I'll have the first one in the hospital and then I might try next time. Well, it's like, well, it's not like a boarding pass. You don't have to have a traumatic delivery to be able to have a beautiful birth. Like, we just had a prime up last week. She blew my mind. I'm not exaggerating. She breathed through these. Like, I was like, are you doing hypnobirthing? She's like, no. I was like, oh my gosh, what is happening? And then she just said, I'm going to push now. I'm like, okay. Great. It's her first baby and it was amazing. It was beautiful. It was like, it blew my mind actually a little bit, but we have first time moms that do phenomenal jobs all the time. And the difference between a first time mom having a successful out of hospital birth and having a crappy birth is her birth team, whether you're in the hospital or out. If you have a good birth team, if you have a good provider, if you have a doula, if you have support, you're more than likely going to have a good birth. Being a first-time mom doesn't actually have very much to do with it at all. It might make the pushing phase a little slower. It might make the labor a little bit longer. But at the end of the day, the mechanisms are the same. Labor is the same. Labor is just as unpredictable in a mom on her 9th baby as it is on her first baby. So you don't have to have this requisite of OB care first. You can have an out-of-hospital birth with whatever number baby it is for you.
I have a question for you about preeclampsia and kind of risk. And I know that somebody else touched on it's a lot of to do with what the provider feels comfortable with. So we planned a birth center birth for my first, and I got to 38 weeks and I couldn't feel the baby move for like 10 hours. We went to the hospital. Obviously our midwife was like, go to the hospital. Like I can't do anything. I did have a vaginal unmedicated birth with a little bit of Pitocin that we pushed against, but they were really concerned about me stroking out. We would love to have a home birth, at least in the birth center. And I'm just curious about how do you feel about people that have had preeclampsia before? Again, I know that each pregnancy can be different, so you can't really tell, but do you have a preference or a hard and fast rule with that?
So that kind of goes back to that individualized variable type scenario. Like you said, preeclampsia, technically speaking, if you've had it once, you are at a higher risk, although that doesn't always mean you'll develop it again. So we certainly have had moms who have had preeclampsia or gestational hypertension in their first pregnancies and then attempt and successfully have babies out of the hospital. Because we do a more integrative approach, they have a more holistic approach to the pregnancy. They're more careful with diet, with exercise, and we can significantly decrease those risk factors. The biggest thing is you just have to understand that with preeclampsia, you can't play with it, right? Preeclampsia is deadly. And so when we do, as midwives, again, we're brilliant at what we do out of the hospital, but the birth isn't the only thing. And we often get so wrapped up in it, the birth. That's true, but our job is to lead you up to that point safely. And at the end of the day, if we see symptoms arising that are going to compromise you or your baby, the best thing we can do for you, the most appropriate thing and the most loving thing we can do for you is transfer. So in situations where moms have had pre-existing conditions like that, we just say, okay, well, here's the risks. We all understand the risks. Here's our plan. This is what we're going to do. And we just have to be comfortable with the fact that at the end of the day, it may result in a transfer. But then again, that's true with all birth, right? Birth is completely unpredictable. So does that answer your question?
Yeah. And so you wouldn't say like, just go straight to the hospital. We don't even want to like touch that because you've had it before. Like there's a chance in trying, I guess.
Again, it's so hard without knowing like the finite details and what the degree was. And I've had women come to me that have been diagnosed with these complications, and I've looked at their labs and they have not met the criteria by any stretch of the means. So it just depends. It depends on whether or not that was a true diagnosis. It depends on what the circumstances were. It just depends. And it's complicated.
Thanks.
But it's possible.
Hello. I don't actually have a question, but I would like to make a statement. With my first child, I had a shoulder dystocia in the hospital, and my OBGYN told me I had a small pelvis and that she would do a C-section on me on my next child. So I had a home birth, and I had another shoulder dystocia, and my midwife flawlessly handled the shoulder dystocia in the water, and it was okay. So don't let your OBGYNs scare you into having a home birth. Into not having a home birth. Also, with that being my past, she was able to look at my records, talk to me. She approved that I could have a water birth, and we did rehearsals about what we would do in the situation of a shoulder dystocia, because if you have one, you can have more and all that. So,
I have a question. I was very low risk, and basically my doctor didn't have any worries about me, but going in, I actually had, his cord was wrapped around his neck, and then I had a rare condition where my blood wouldn't clot, so I continued bleeding. I guess my question is, has there ever been an instant where, you go into the birth thinking that everything's going to go well, but then things go, or there's been a surprising case? Has there ever been an instant where you have to transfer to a hospital or anything like that? Or like what goes on during those situations?
That's a great question. Yes, that does happen. It does sometimes. And again, we are trained to manage it. And so it really depends. Again, birth is very unpredictable. So it depends on, what degree of emergent are we talking? And we've had, some hemorrhages that we've had to transfer, or tears you have to, things happen, right? Birth is unpredictable, like I keep saying. So yes, that can happen. But typically speaking, again, most of the interventions that you see put in place in the hospital for things like hemorrhage or this or that are the same interventions that we impose at home. We don't do surgery. And of course, if it escalates to a point where we can no longer manage it, then we'll transfer. I think it's often helpful to remind families, and this isn't all encompassing, and this doesn't mean everybody, and that there's never a true emergency. Yes, of course, never say always or never. There can be true emergencies, and that's horrible and devastating. And that can happen in the hospital. And also, most hospitals they don't have their ORs prepared for you to fly in. It takes time to prepare the OR and time to prepare the mom. And typically speaking, that's about 20 minutes. And the time it takes you to call the ambulance and transfer to the hospital is the same amount of time you would spend in that bed being treated, is the same as you would being treated in general. And so that's not to minimize things that do happen. Certainly sometimes stuff does come up. You have shoulder dystocias, you have hemorrhages, you have babies that need a little bit more help, and they're never fun. But in general, they're manageable, right? Because again, babies really want to live. Moms typically really want to live. And we're fortunate that we do have medical resources. We do have the advantage of being close to hospitals, or typically, we have EMS wherever you are, whatever. So I don't know if that answers your question, but yes, stuff can happen for sure. There's no risk. There's never no risk though. Babies die in the hospital, and actually quite at a frequent rate. It's a little bit disturbing. But because it's in the hospital, it's like accepted. Oh, sure. Well, my doctor, did this. Or my doctor saved my baby from this horrible thing. I'm like, yeah, well, that horrible thing happened because of all the stuff your doctor did to you in the first place. So there's a million ways to cut that one, right? There's a million ways to slice that one. But at the end of the day, no birth is without risk. That is just human nature. No birth goes without risk. But if you find a skilled attendant, you can mitigate the majority. You can mitigate the majority of that risk or have someone that is skilled enough to get you where you need to be in order to manage the final stages of that risk. And so I'm going to caveat off that really quick. I don't even know how much time we have left, but I'm going to touch real quick on free birth, because I think sometimes people think like, oh, homesteading birth, like midwifery, yay, free birth. Actually, if you want a free birth, at the end of the day, again, whatever you choose is 100% your decision. But I will say, because of that very reason, I don't encourage it. And as a midwife myself, I have midwives. And as a midwife myself, my third baby was a surprise footling breech. And holy shit, excuse my language, but there's not a chance I would have been able to manage that myself. Absolutely not. And I'm a skilled provider, and I can handle breech, and I can handle a lot of stuff, but not when I'm pushing, right? And so women are typically not in a place to handle that, and their husbands are typically not in a place to handle that. So anyways, that was my little caveat off to like, I don't hate free birthers. Please don't take this as like some... But be really, really careful and methodical and take a lot of consideration in that and what that might actually look like for you. Okay. Sorry.
Thank you.
All right. What percentage would you say has been an emergency and you did have to transfer in your experience?
Transfers for true emergencies? I don't know. I guess it's a very low number. I can count on one hand the amount of times I felt like this is a true emergency. And then there's levels, right? There's, you're bleeding a little more than I'd like. We might want to have this checked out. And then there's like, oh, no, we got to go. Like, we need to leave right now. But you have to think again, 80 to 90% of moms are low risk. Most of these huge complications and these really scary things aren't happening to the 80 to 90%. They're happening to women with pre-existing conditions because they already have health considerations that are putting them at risk. So for the 80 to 90%, their relative risk is pretty small. Does that answer your question?
So I have a statement kind of more than a question. I've had 3 births with 3 different midwife, one in Texas, one in Tennessee. My last was a home birth in Tennessee. They're all different. So don't think just because you're going with a midwife group, even in a hospital setting, that you're going to get the support that you might want. So just interview. And yes, because my births would have gone, I think, a lot differently had I interviewed and not just thought, oh, I'm going to go with the midwife group and it's going to be awesome, because one of them was not awesome. So
that's very true. Take the time, do your diligence, interview as many as possible.
Hey.
Oh, good. A dad, yay.
Am I on? Yeah. So obviously I won't be having any children, but any babies birthing, and we have 4 already, my wife. But I do have a question. One of those 4 we're homesteading and all that, and over the years, as we don't want this just to be what my wife and I do, and then our children go on into living in the corporate world and all that. And so one of our girls has expressed interest in, if I pronounce it correctly, midwifery. Mm-hmm. And so I just had more of a question. She's getting to the ages where she can start furthering her education. Had a question with regards to training, and also like what some things we can do to kind of facilitate that in terms of what area of science or whatever might be a good track for her, and then ultimate certification and things like that. What is that process?
Yeah, that's a great question. Also, there are a lot of ways to slice that pie too. So there are different types of midwives. You have very traditional midwives who are unlicensed and maybe never attended any formal training, and that's just kind of like the given name for them. It's really subjective, right? Because people call themselves by a lot of names, so there's a lot of splitting hairs when it comes to midwifery. So you have that type of midwife. You have midwives who are CPMs. Like I'm a CPM. So essentially, the majority of my training was done through apprenticeship. I spent 7 years within different practices, learning how to do what I do, attending births, attending clinicals, attending school. And so you can do that pathway. You can do an entirely apprenticeship-based pathway through the North American Registry of Midwives. You can go to college. You can do whatever fits you. Personally, I never wanted to work in the hospital setting. I had zero interest in being a nurse midwife. It's nothing against nurses. I love nurses. I love my nurses. It's great. But I don't want to work in the system. I have zero desire to work within the system. And so I needed to find training that was suitable for me. But for some midwives, they want to work within the system. Maybe they want to change the system. Like maybe they have really high endeavors, and that's great. Then they would need to go a more medical route. So it just depends on what she's looking for. What she's looking for, because you could have midwives that travel to other countries and learn from indigenous midwives and have no interest in any systemic education whatsoever. It just depends on what her desires are. Okay. Yeah. And that goes back to that interview process and finding who works for you, because some women want to have a baby in Hawaii in the water with dolphins, and that's totally cool. And there's a midwife for that. Like, really, there is. It's, and I'm sure she's super lovely. If someone asked me to do that, I'd probably be like, I don't know, you might want to interview someone else. I don't like dolphins that much. But, it just depends. So there's a midwife for everybody, and it just depends on your daughter. Who is she? Who is she serving? And then she needs to just follow that direction and take her education in a place that points her to the people she wants to serve.
Okay. I want to make one more comment to our friend over here with the preeclampsia earlier. I just want to make a statement really quick and kind of tie together something that the presenter mentioned. When you're a holistic practitioner, you look at the labs differently and interpret them differently than what a conventional practitioner was. I spent 12 years in ER. Okay. I can tell you for a fact, it is completely different. It's not, when she was talking about earlier, the preeclampsia being a risk factor, so to speak, for the next time around, is because we don't know it in conventional medicine. It's like, do we medicate or do we not? In holistic medicine, it's what was the root of the preeclampsia. And in conventional, a lot of times they jump to, well, it's your BMI. Well, I have news. That's not the case all the time. And so anyway, that I just wanted to kind of put that together for those who may have struggled with that.
Oh, cool. So I know. Oh, sorry.
It's cool. Okay. Hi. So I did not want to have a hospital birth, but I have been diagnosed with gestational diabetes, so I have to now. I'm not happy about it. And I've been getting all this pressure from my providers, like, oh, we really don't want you to go beyond 39 weeks and we'll like induce you and stuff. And I'm like, I want to avoid being induced. I want to avoid Pitocin and all these things. And actually the hospital where I'll be going has, it seems, a lot of support for a lot of like natural birth things that I like. Like, yeah, you can do upright positions and stuff like that. Lots of things that I cared about. But I'm just, I'm getting some pushback in some areas, and I'm just wondering what are some ways that, I can, like, how successful might I be with, like, no, really, please don't give me Pitocin unless it's a medical emergency. Like, I won't stop bleeding. Someone mentioned maybe giving it to me during labor. I'm like, I don't want that. I might not need it. That sort of thing.
Yeah. That kind of goes back to the advocacy. I would say in general, having a doula and also having a plan. And then remember, at the end of the day, and this is very important, you hired the hospital and you hired your provider, and actually they work for you and they cannot do anything you don't consent to. Now, I'm not saying you go in with these like unreasonable expectations that are going to put anybody at risk, but in general, if the baby's not in danger and they want you to do Pitocin because it's not going fast enough, you absolutely have the right to say, no, thank you. I do not consent to this. I do not consent to this procedure. I do not consent to a vaginal exam every 5 minutes. I do not consent. It's that simple. I do not consent.
I've heard things like the hospital will fire you as a patient if you push things far enough. And I'm just like, I mean, at what point is that?
They're not going to kick you out in labor. Like, what are?
Okay.
They can't do that. That's highly unethical, right?
Okay. I've got another question, but I'll let the other people go first.
Okay. Go ahead.
I've had 9 babies, and 4 home births.
Good for you.
And I'm a naturopath in Virginia. And what are your favorite books and what are your favorite things to study so that you can learn true, like natural home birth and herbal remedies and things like that?
Well, you can as doulas. That's kind of a different question. So for doulas in general, their scope of practice is typically limited to emotional and physical support. And so some might know a lot about herbs or homeopathy or things like that. But in general, I would say maybe leave that more to the practitioner. But if she really wants to understand birth, there's lots of great authors. Any book by pretty much any midwife is generally pretty fantastic. Call the Midwife's really great. And
what do you think of Aviva Ram?
Ina May Gaskin writes some really good books. Aviva Ram is pretty good. She is really great. I shouldn't say pretty good. She's incredibly educated. There are lots of good resources, but I would say the biggest thing with being a doula and understanding birth is being there. You can read all the stories. You can read all of the books that you want, but until you're there and you experience it and you see it, you're not really going to truly understand and be able to encompass what that looks like and how holding that space and providing that support really is. But yeah, I mean, there's lots of great authors. Everyone loves Ina May Gaskin, right? Does that answer your question?
Oh, yeah. Okay, so yay, I'm gonna poop on here. Okay. Anyways, so
I'm like, am I running over?
Oh, yep. Hold on. Go for it.
Are we in? We're in. Okay, cool. So for and maybe I'm using the wrong terms and stuff like that, like care after baby is born in a hospital setting versus doing it this way. Like, I'm probably, there's some people here on the line, like, I don't want my baby taken away and then jabbed with vaccines and stuff like that and then handed to me in a towel. Like, I want that more natural experience. So what can I kind of expect going a more natural route with a doula or a midwife versus doing it in a traditional hospital setting as far as the care of my baby, like post-delivery?
So I just want to add real quick. So doulas are not medical providers. I just want to be very clear on that. So they don't have anything to do with that component of care. They might help with breastfeeding and emotional support, but they shouldn't be providing medical care in any capacity, period. Okay? I just want to put that out there. I love you guys so much, but there's a huge divide. And so postpartum care, actually, that's another really wonderful question. Postpartum care with midwifery looks very different as well for several reasons. One, we love to initiate that immediate skin to skin, lots of bonding with baby. We are actual breastfeeding advocates, not like a breastfeeding friendly hospital. And then, never mind. But essentially, we do set you up for that. And then in the hospital, right, you're getting bugged every what? You're a postpartum nurse. How often do they do checks? Every 15 minutes, it spaces to every few hours. And so in the concept of rest and relaxation immediately postpartum, that's a joke, right? Like, oh, get some rest. But actually, hey, I know it's 2 a.m., but we need to wash your baby now. Like, oh, okay. Well, they're actually sterile, so that's fun. But so postpartum in an out-of-hospital environment, we either tuck you into your own bed, which is my favorite, right? We get everything cleaned up. You'd never be any of the wiser that a baby was just born in this house. You walk in and there's just a tiny person there. And you clean your stuff up. You pack your bags up. You give them all of their good debriefing things. And then you tuck them into bed and you go away and they sleep. And then they breastfeed. And then they bond. And they rest. And they actually rest. Or in a birth center environment, we keep moms as long as we feel like we need to ensure that they're stable, that baby is stable. And then we release them into the wild and they go home into their own beds and they rest and they relax there. And typically midwives come and do a home visit within 24 to 48 hours to check in on the well-being of both mom and baby, to make sure bleeding's under control, to make sure baby's healthy, to do weight, do all the things. And of course, before we leave, we make sure the parents fully understand what to look for. Right? If there are any concerning signs or symptoms that you need to be aware of before we leave so that you can feel comfortable just being home alone and not being stabbed or prodded or rubbed or whatever they do. Do you want to add anything to that? Because that's your arena.
When all the alarms and the beeping and like you have to reset this.
It's very soothing. The beeping is very soothing. So, yeah. Does that kind of answer your question?
When should the cord be cut? I always heard that you're supposed to leave it, but my sister just had a baby and they're like, no, cut it now. and she kind of wanted to leave it. So I don't know if that's beneficial or is it not?
No, it's super beneficial, right? Because I think it's a third of the baby's blood volume if you clamp it immediately after birth, which if you lost a third of your blood volume right now, you'd feel like hot garbage. So imagine how a baby feels. It's a loaded question. There's a lot of variables. If you have to cut a cord because of a medical reason, sure, you might cut the cord early. I forget to cut the cord 9 times out of 10. It's fine. It drains into the baby where it belongs. Some women leave the cord and the placenta attached. Sure, that's your wheelhouse. That's fine too. I would say in general, we probably do maybe an hour? It can be an hour, yeah. The short version is once it's stopped pulsing, it doesn't matter. It's just there. It's just attached. Cutting the cord at that point is just to remove the placenta from the area so you don't have to carry a bowl with your baby.
So in the hospital, they will cut it super fast, more for efficiency. So that way that they're just able to move things along. And they'll sometimes tell you things like, oh, your placenta can't come until the cord is cut. Or I think my favorite is blood will flow back to the placenta and baby won't get it, which is not how that works at all. So if you do go into the hospital, that is something that I know, when I'm supporting moms or I've had 2 hospital births, just to be mindful of, because they'll say things or they just want to get things going. Whereas the birth we had the other day, we were able to help baby out a little bit with the cord was still attached.
Yeah. So that's one of the things too, goes back to that medical thing. Honestly, so my favorite is EMTs. I love EMTs. If there's any EMTs here, God bless you. We love you so much. And also they don't see a lot of brand new neonates, right? And so if you've ever had to, we've had to resuscitate a baby before, and that sucks, and it's hard, and it's really not fun. But they come in, and we call 911 because we're doing a really intense thing, and that's what you do. It's appropriate. It's the safest thing to do. And they run in, and they got their dirty scissors, and they're like, let's cut the cord. And I'm like, absolutely not. You're not doing that because the cord has oxygen and blood, and that's what's keeping your compromised baby quite alive. So, yeah, we don't do that. We just don't do that. That's a great question. She asked, where can you find a birth center or hospital's policies? I would say with a hospital, Godspeed. Most birth centers do have their policies and procedure manuals completely available to you. Again, with midwifery, it's a total transparency of care, right? Informed consent. Here's my protocols. Here's what I think we should do in these specific circumstances. Let's talk about it. In the hospital, I actually don't know. I would say you could ask them. I'm not sure what they would give you. You'd probably be better off looking up ACOG guidelines, which is the American College of Gynecology and Obstetrics. And so if you just look them up and Google it, you'll probably have to pay for a subscription because it's ACOG. But it will have all of their recommendations on that website.
So, sorry.
Go. Right, a backup birth plan. And we do, we discuss that with our moms typically just in case, because you just never know. Birth is unpredictable. So you can always pack a birth plan. I will say keep it 1 page because otherwise the nurses will not read it.
So I was wondering if there's anything particular to being on a homestead that you would, that comes to mind about anything being out in the country or anything like that that's of particular importance just from this perspective?
From homesteading, I would say the biggest things is in general with homesteading, we're getting kind of back to our roots, right? The way we're designed to be, not in these big cities and these really ridiculously busy lives. And I think that inherently it's a proper environment. Right? You have sunshine, you're outside, you're moving, you're doing chores. So you're moving your body, you're eating the foods that you're growing. So you know you're not getting a bunch of junk and preservatives and all of the fun additives that they're going to swamp in there. And you're getting vitamin D and, it's just a healthier lifestyle. And I'm skeptical to say maybe it's less stressful because sometimes it might not be. But in general, if your life is low key and you're living like we'll say the ultimate homesteader's dream, right? Then of course, like where else would you want to be pregnant or have a baby? That sounds idyllic. Yeah. Do you have any thoughts on that? You're more of a homesteader than I am.
Well, is she asking from the transfer perspective?
Oh,
being far out. Is that what you're asking?
Oh,
just anything like that. Any kind of like, oh well, this is a special case because you're out on the homestead. Like, is
you mean like away?
Yeah.
Oh, I totally misinterpreted that. I mean, that's a consideration is transport to a hospital, the length of transport.
Or like, is there any sort of circumstance where it's like, you need to know how to do this sort of thing because it might take us longer to get to you?
Yeah, well, we actually tell all moms, we tell all dads at our birthday planning meeting how to catch a baby, like very basic 101, right? And it really, actually, I'll tell you now for free. Ready? It's just keep the baby dry and warm and call me. Yeah, perfect. Don't touch the cord, okay? And hang out. And that's essentially what we go over. Hey, if this is a precipitous labor or if I can't get to you for some reason, here's our options. You can call 911 if you want. Please have me on speakerphone. I'm going to walk you through as much as possible. But I would say for like the 99%, most babies that come at home that quickly, it's just because like everything's fine. All the stars aligned and it's perfect. And those babies generally do extremely well.
I just want to make an observation. We went into, initially we were going to do a hospital and then we transferred to a birth center and then eventually had to go back to a hospital. And because we were initially going to the hospital, we had to educate ourselves on a lot of stuff going into it with our first. And when we ended up having to go back to the hospital because of preeclampsia, having educated ourselves, kind of the point that this lady was making, was such an advantage because we weren't scrambling to try to figure out what was important, what wasn't,
right.
What to fight them on, what you don't want to fight them on every single thing because some of it might actually be necessary given the circumstances. So I would say even if you are going to a midwife, I think it's really important to inform yourself on sort of all the different factors that modern medicine uses because you may find yourself in a certain situation you want to help.
Right. Right. And that kind of is where that educational piece comes in, is understanding. I mean, you're not going to have the full spectrum, right? There's just no possible way for us to educate you on everything that could possibly go wrong. That's extremely unrealistic, but it is good to prepare yourself in general for the big things that might come up. And that's something that as midwives, we typically do. We talk about that in the birthday planning meeting. We talk about transfers, why transfers might occur, and how those transfers might look. Because if we do have to transfer, the last thing we want is for it to be traumatic. Because ultimately, if it can't be at home and it can't be at the birth center, it can still be beautiful and we still want it to not be awful and suck. So we talk about this is what this looks like. This is what you'll do. This is what the midwife will do. This is what this will look like. And here's what we do when we get there. So that at least if that has to happen, it's not a shotgun blast. It's not a huge shocker. We're still moving through it and it can be peaceful and as peaceful as it can be.
And just from my experience in the hospital, I'm not working in there anymore, obviously, but we notice the minute a couple comes in educated. You notice that because the majority of people are not educating themselves about birth. So they do walk in, they get the epidural, they do what they're told because that's just the system. That's just what we do. But I could walk into a room and within minutes realize that this couple knew what was happening. So it does make a huge difference even to how the staff is going to treat you because they just realize, oh, they're taking ownership of this. Okay, this is how we're going to move forward. So it does make a difference.
Anyone else?
What recourses do home birthers have who tend to go past 42 weeks? Do you run up against liability?
Dun, dun, dun. 42 weeks. Sometimes we do run up against that. The recourse for 42 weekers. So as you all know, babies have a due date of 40 weeks. Fun fact about due dates. That was based off of 19 women or something, hundreds years ago, 100 or more years ago. It's pretty much irrelevant, actually. 40 weeks is, in my opinion, a pretty arbitrary number. I don't know very many women ever that go exactly 40 weeks on the button. It's just kind of a general idea. It's a concept. And so in general medical practice, most moms are not allowed to go beyond 42 weeks, right? That's a really complicated one too, because one, dates can be wrong, right? There is a variance in when the, conception occurred, implantation, how old is that baby really? Were the scans accurate? Did you even have scans? It goes the whole thing. And then also, what do we really know about beyond 42 weeks? Yeah, because it doesn't happen, right? You're not allowed. So it boils down to the independent midwife. It boils down to her experience and her comfort level with going beyond 42 weeks. For context, we used to think there was like a timer on the placenta, right? Like it's like your dinner and it's like, ding, okay, well, you're done. Now you can't be pregnant anymore. But that's not really how the placenta works. It's true. It does lose efficiency the further past 42 weeks that you go, but that doesn't mean that it has to be a line in the sand. And you just have to find a provider whose protocols who's comfortable with maybe pushing past that. And I know for myself, generally speaking, if I have a mom that knows she goes late, because some women just historically, they just go late. That's their pattern. If they know they go late, then we might say, okay, well, we'll all agree that for the sake of like a community standard, that maybe at 41, 42 weeks, you'll get a biophysical profile. So we can make sure your baby's nice and healthy and happy and that your placenta is working well. And then you just stay pregnant until you have a baby. And like, there might be other things added on to that. It just, again, is very highly dependent on the circumstances. And again, at the base of everything, at the mom's comfort level. I've had moms who don't want to go past a certain date, and that's fine. That's your comfort level. That's my job, is to support you. And I've had some moms that are like, I really don't care how long I'm pregnant. And you're like, okay, all right. So it just depends. It depends. But it's again, it's my opinion, it's a little bit arbitrary. And it depends on your midwife. The hospital will not let you go to 42 weeks. Of course, we watch for baby's size. We have mom track fetal movements. The biophysical profile is intended to be kind of an inside view of like, how is the baby doing? What does the placenta function look like? What's the baby's size, so to speak, even though there's a 3-week variance in the third trimester or up to, but there's a lot of things. It just boils down to the variables and the mom and the baby.
Do you have a place where you are where people can find you to ask more questions?
Yeah, if you want to ask questions, we can always like hop outside the tent. I'm probably out of time. I really don't know, actually. Where are we? We have like 5 minutes. But yeah, we can always pop right outside the tent if anyone has more individualized questions or just in general doesn't want to say them out loud. Anyone else?
So I've gone like 41 weeks with all of my children. And at that point, my AFI was at about a 5. So every time I was told that I had to be induced. What's your opinion on like a critically low AFI and the need to induce?
So she asked about AFI, the amniotic fluid levels in late pregnancy, and what would be considered critical.
So I was at about a 5 with all 3, with the baby was healthy and fine, and I was told at almost 41 weeks with all 3 of them. Like I had no option. My water had to be broken and I had to leave.
Yeah. Amniotic fluid is one of those interesting things, and it can sometimes be indicative of a concern. So, of course, we want to dig in and see what's the root, or if we can find a root for why that might be happening, why that amniotic fluid might decrease. But in general, in late pregnancy, it does decrease. Makes sense, right? Because you're done being pregnant. I don't have a firm line in the sand for you on that one. It really, again, for me, a lot of it boils down to. There are some things I am very strict about, but in general, it boils down to how is mom doing? How's baby doing? If baby's got their AATs are great, like their acceleration tests are great, they're doing well, they have lots of movement, and we know the amniotic fluid replenishes every 3 hours. So we know we have a mom who's going to work really well on hydrating, and the baby's doing well. Then maybe we have wiggle room. It just depends on the mom, but in general, your AFI does go down the longer you're pregnant. Oh, and back to the due date thing, 41 and 4 is actually the most common due date. 41 and 4, not 40. Okay. Next.
Would you consider someone who had a previous deep vein thrombosis or pulmonary embolism as a high risk for
DVT or pulmonary embolisms? That would be definitely a riskier category. Right, because for women who have had a history of DVT or pulmonary embolisms, they have a higher subsequent likelihood, and that's not typically something that you really want to be dealing with outside of the hospital. So again, that kind of is that it's unfortunate, but not every woman can give birth at a hospital, right? I'm a realist. I'm well aware not every woman can, and that doesn't mean she's broken or it's bad. It just means she needs a different type of care. But there are some things like that do increase your risk.